and fields of all medicine. In this explainer, we're going to explore our essential toolkit, the absolute foundation of descriptive psychopathology. We'll be breaking down the specific signs and symptoms of mental disorders, how to actually spot them, and how to structure those clinical observations so they make sense. Okay, so right out of the gate, we're hit with the ultimate core challenge of psychiatry. How on earth do you diagnose a condition that you can't see on an x-ray or verify with a quick blood test? Unlike pretty much every other medical specialty, we don't have a magical lab value to confirm a diagnosis of, say, schizophrenia or major depressive disorder. Instead, we have to rely heavily on careful, highly structured observations and incredibly detailed patient histories. Our primary diagnostic instrument? Well, it's our own clinical perception. Okay, let's dive into this. We are going to open up the psychiatrist's toolkit and set the stage for the foundational concepts you absolutely need to master. Think about general medicine for a second. It's usually pretty straightforward, right? There's a very clear separation between a symptom, which is what the patient complains of, and a sign, which is what the doctor physically examines, like jaundice or a heart murmur. But in psychiatry, the game is distinctly different. Aside from a handful of exceptions, like the weird motor abnormalities you might see in catatonic schizophrenia, we have very few traditional medical signs. In our field, a sign is usually an observer-noted behavior. Maybe it's a patient who appears to be responding to a hallucination, or maybe it's a whole aggregated group of symptoms that we interpret together. So how do we handle this daily medical detective work? It really comes down to comparing what a patient is telling us versus what we can physically observe. To make sense of it all, we break everything down into subjective and objective features. The subjective features are simply the patient's direct complaints. For example, a patient looking at you and saying they have a persistently low mood and just feel tearful all the time. The objective features, on the other hand, are what you, as the clinician, physically see and hear during that interview. We're talking about things like poor eye contact, psychomotor retardation, or the fact that they are actually crying in front of you. When both of these align, boom, you have incredibly strong evidence for your diagnosis. But what happens when they conflict? Because, trust me, they will. This is exactly where our clinical responsibility kicks in. Imagine a patient sitting right in front of you, looking visibly devastated. They're crying, they've got obvious psychomotor slowing, yet they sit there and flatly deny feeling depressed. When subjective and objective evidence clash like this, the objective signs usually carry much greater weight. You might still diagnose a depressive disorder based purely on what you observe, but you absolutely have to explore that discrepancy with the patient. All right, let's move on to something that can be a bit tricky at first, the crucial distinction between form and content. Basically, we have to separate the type of experience a patient is having from the specific subject of that experience. If a patient tells you they hear voices when they're totally alone, and those voices are calling them a homosexual, the form of that experience is an auditory hallucination. The content is the statement about being a homosexual. Now, if a totally different patient hears voices saying they are about to be killed, the content is completely different, but the structural form, that auditory hallucination, remains the exact same. So the crucial point is that form dictates your diagnosis, while content dictates your risk management. The simple presence of an auditory hallucination points you immediately toward a psychosis. But if a patient just has intrusive, repeated thoughts about being homosexual that they logically know aren't true, the form there is an obsession, which points toward OCD. Make sense? The form gets you to the right textbook chapter. The content, however, is what the patient prioritizes, and it alerts you to the real-world risks, like if a delusional patient might actually attack someone they think is persecuting them. Another major distinction you'll need to make is whether symptoms are primary or secondary. Now, this can mean temporal, like literally just tracking which symptom happened first, or it can be causal. For instance, say a patient starts hearing accusing voices, and as a direct reaction to that terrifying experience, they develop a delusion that they are being hunted by persecutors. In that case, the delusion is a secondary symptom. It popped up directly as a reaction to the primary pathology. Now, I need to warn you about something. Relying on just one clinical clue is incredibly dangerous. Let me tell you a bit of a cautionary tale. To really grasp the danger here, we have to look back at the legendary 1973 Rosenhan study. It is a shocking story. 8 entirely healthy individuals, pseudopatients, presented to psychiatric hospitals with one single complaint. They heard a voice saying the words, empty, hollow thud. That's it. They denied all other symptoms, and they behaved completely normally on the ward. Yet all 8 of them were admitted and wrongly diagnosed with schizophrenia, based entirely on that single, isolated symptom. It's a massive wake-up call for our field. The lesson here is crystal clear. With the rare exception of an unequivocal, deeply persistent delusion, a single symptom is almost never enough. We have to hunt for a complete syndrome. A syndrome is a defined group of symptoms that aggregate together to form a true diagnosis. Finding one symptom isn't the end of your investigation, it's the trigger. It means you need to launch a thorough, repeated search for more clues. But psychiatry isn't just about coldly defining clinical rules. Let's shift focus to the human element, the actual arts of understanding. And this brilliantly illustrates philosophical concepts established by Karl Jaspers way back in 1913. He defined two specific forms of understanding. On one side, we have erklären, or explanation. This is when we account for symptoms via external factors, like you might explain a patient's suddenly low mood by the fact that they recently lost their job. On the other side is verstehen, which translates to meaningful understanding. This is the intuitive empathy required to truly appreciate the patient's subjective experience. It's the ability to actually feel what it is like to be in their shoes. Achieving this meaningful understanding means you have to adopt a life story approach. You literally have to understand the patient like a biographer would. You need to grasp how the illness has shifted their personal hopes, their self-image, and their whole worldview. A depressive disorder hits a person who has lived a highly successful, joyful life very differently than it hits someone who has just barely survived on a string of fragile hopes. You absolutely cannot learn this from a textbook. You learn it by sitting down, shutting up, and truly listening to your patients. Let's bring this back to practical, everyday applications. We're going to focus on the most common disturbances you'll see in a psychiatric rotation. So the bread and butter of our daily evaluations is emotion and mood. Historically, psychiatry drew a pretty strict line between the two. Mood was seen as the prevailing, prolonged emotional background state, kind of like the climate. Affect was the more transitory, object-linked emotion, like the daily weather. Now, today, especially in our modern diagnostic systems, these terms are honestly often used interchangeably. But keeping that historical nuance in the back of your mind will really help you observe emotional states much more precisely. So, how do we actually evaluate if an emotional state is pathologic? Well, here is your clinical checklist. Emotions can be abnormal in three primary ways. First, their fundamental nature might be altered. Second, they might fluctuate way more or way less than what is typical. And third, they might be completely inconsistent with the patient's thoughts, their actions, or their current circumstances. Let's look at that first one. When the nature of the emotion is altered, we see states like severe anxiety or depression. Depression brings these gloomy preoccupations, a furrowed brow, and real psychomotor changes. When we look at reduced fluctuation, we call this emotional blunting or flattening. The patient's emotional range is severely restricted. And severe flattening, which we often term apathy, is a highly significant observation. It very frequently points us straight toward schizophrenia. Then we have inconsistent or incongruous emotion. This is a classic clinical presentation, and frankly, it can be really jarring. Picture a patient sitting in front of you, cheerfully laughing out loud while discussing the recent tragic death of their own mother. Now, you have to be careful to distinguish true incongruity from someone just doing that awkward, nervous laughter. But when it is genuinely inappropriate, it is a massive diagnostic red flag. Let's move to anxiety and see how this builds into our framework. Anxiety itself is a perfectly normal mammalian survival response, right? It prepares us for flight or fight when we're facing real danger. But it crosses the line into abnormal pathology when its severity is completely out of proportion to the actual threat, or when it vastly outlasts the danger itself. At that point, it stops being a helpful preparation tool and mutates into a crippling barrier. Finally, we must constantly be on the lookout for irritability and anger. Irritability is essentially a state of increased readiness for anger. Clinically speaking, it spans almost every disorder in the book, from anxiety and depression all the way to mania and dementia. Because of that, it actually has very little value in helping you pin down a specific diagnosis. However, it has immense, absolutely critical value in risk management. Recognizing irritability early is vital for predicting and managing potential harm to the patient or to the people around them.